Central sensitization is one of the most misunderstood concepts in chronic pain and in neuropathy. A lot of my patients come in having heard some version of the same thing from multiple providers. We've tried everything. There's nothing more that we can do. This is just how it is when it comes to neuropathy. And honestly, I understand why that happens. The medications have been adjusted. The referrals have been made. The testing have already all been done. And sometimes the findings still don't fully explain the severity of what the patient is actually experiencing. So eventually, the conclusion becomes that the patient has simply reached their ceiling. And the bothering part is patients carry that with them, and not always angrily, not questioning whether their pain is real, just a bit more resigned. Like the best case scenario now is managing symptoms instead of actually improving. This video is about why that conclusion is incomplete, because there's a piece of the picture that is often doesn't show up clearly on standard testing and is not always addressed directly. And that piece is called central sensitization. And I want to explain clearly what it is and what it is not. Because central sensitization does not mean the peripheral nerve problem just disappeared. It does not mean the damaged nerve fibers stop mattering. And it does not mean that the symptoms are in your head. It means the nervous system processing the signal has also changed alongside the peripheral nerve damage. It is what happens on top of the peripheral problem and not instead of it. At its core, CS describes a nervous system that has become excessively reactive after prolonged exposure to abnormal sensory input. In other words, the system processing the signal has changed over time. And in neuropathy, that matters, because when peripheral nerves have been irritated, inflamed, metabolically stressed, or firing abnormally for long enough, the central nervous system does not just ignore that input, it adapts to it. Over time, it becomes more sensitive, more reactive, and more easily triggered. And eventually, the threshold for producing pain can become significantly lowered. That is central sensitization. We often refer to it as CS, and CS is not a reason you cannot improve. It is a mechanism, and mechanisms can be worked with. So let me start off now by hearing a question that I hear constantly. Why do two people with roughly similar nerve damage, similar EMG findings, and similar metabolic history experience their neuropathy so differently? One person has noticeable symptoms that are manageable. The other is in constant and severe pain. They can't sleep, they can't function, and they describe the burning and electrical sensations as unbearable. Now, this is the same diagnosis, but two completely different experiences. Part of that answer is central sensitization. Your nervous system is not a passive cable that simply transmits signals. It is an active, adaptive processing system. And one of the things adaptive systems do under sustained unresolved stress is it increases its sensitivity. Now think about what that means. When peripheral nerves have been damaged, firing erratically, or sending distorted signals, and that has been happening for months, or let's say even years, the nervous system doesn't just sit there passively absorbing it. It responds and it adapts. And the way it adapts is by becoming more alert and more reactive. It's more easily triggered. It raises the alarm at a lower threshold. Because from a nervous system's perspective, something abnormal has been happening for a very long time. And the answer to sustained threat is to become more sensitive to threat. That increased sensitivity is originally a protective thing that the body does. It evolved for very, very good reason. The problem is that in chronic nerve disease, it becomes maladaptive. The system starts amplifying signals that do not need to be amplified, and eventually it starts generating alarm in the absence of proportionate input. That's the beginning of CS. Now, it's not the body's weakness and it's not fragility. It's biology responding to sustained stress the only way that it knows how to. And this is important because most people still think about pain as if it works like a direct wire. Something hurts, a signal travels, the brain then receives the signal, and end of story. But that's not actually how the nervous system works. The nervous system is constantly interpreting, filtering, prioritizing, amplifying, and suppressing information. It's not just measuring the input, it's deciding how threatening that input is. And when a system has spent years receiving abnormal peripheral nerve signals, it begins recalibrating itself around danger. That changes the entire sensory experience of a patient. This is why some people eventually reach a point where symptoms no longer feel proportional to the original trigger. The system itself has already changed, and once the system changes, the nervous system can begin responding aggressively to inputs that normally would not even register as threatening. This is the symptom that confuses most patients, and honestly, sometimes from what I hear, it confuses providers as well. A bedsheet touching your feet at night feels unbearable. Socks end up feeling like sandpaper. Warm water on your legs feels like steaming hot burning sensation. And a gentle tap on your ankle produces pain that is completely disproportionate to the stimulus. These are not normally painful inputs. In a healthy nervous system, these signals are processed, classified as safe, and filtered appropriately. So why does a sensitized system respond to them with pain? Your spinal cord contains neurons responsible for processing incoming sensory input. Normally, there's a threshold, and an input has to reach a certain intensity before those neurons even fire strongly enough to generate a pain response that reaches our conscious awareness. But in central sensitization, that threshold drops. The neuron becomes hyper-excitable. Their resting activity is already elevated, so now it takes very little to push them over the edge. Light touch can now trigger them. Slight temperature change can trigger those neurons, and sometimes even the pressure of a blanket can trigger them. And when those neurons fire, the brain receives a pain signal. Not a light touch signal, but a pain signal. The input was light touch, the output was pain. That gap, that is a central sensitization. Clinically, this is called allodynia. Pain is produced by a stimuli that normally should not produce pain. And in my clinical experience, it is one of the most disruptive parts of chronic neuropathy because it makes normal life so difficult. You can't tolerate normal socks. You can't sleep under a blanket comfortably. And your environment starts to feel threatening. And when nobody explains why this is happening, patients start to believe something catastrophically is wrong with them, which then feeds the nervous system's threat detection. Once the threat detection is alarmed, this makes sensitization even worse. So understanding this is not just academic, it directly affects how patients interpret what they are personally experiencing. Now I want to go deeper into the mechanism because I think people need to understand what is actually happening inside of their nervous system. And not thinking about it at a textbook level, but at a real understandable level. Now, there are several biological changes that happens during central sensitization. The first one is called windup. In a healthy nervous system, a pain neuron fires, sends a signal, and resets. So signal in, signal out, then reset. But when there's a repetitive, sustained input, which is exactly what happens when damaged peripheral nerves have been firing abnormally for months or even years, those neurons, they stop resetting normally. A receptor called NMDA receptor becomes persistently activated. And once that happens, the neuron's response to incoming signals, that becomes amplified. The same signal no longer produces the same input. It produces a larger output. And the threshold to trigger that output becomes lower. So now the system is amplifying more while requiring less input to do it. That is a major part of why symptoms escalate over time. The same level of peripheral irritation that produced manageable symptoms early on can eventually produce overwhelming symptoms later because the processing system itself has now become amplified. The second mechanism is loss of inhibitory control. The nervous system is not just an amplifier, it also acts as a braking system. There are inhibitory neurons whose job is to calm the system down and place a ceiling on how much amplification can actually occur. These systems use inhibitory neurotransmitters like GABA and glycine to regulate signal intensity. But under prolonged sensitization, those inhibitory systems become less effective. Now, that means the brakes are now becoming weaker. And when you combine weakened inhibition with increased amplification, the result is a system that can become relentless. The pain no longer fluctuates normally. The nervous system struggles to settle itself down, and patients start describing symptoms that feel constant, intrusive, and just exhausting. And the third mechanism is glial cell activation. Most people may have heard of neurons, but much less have heard of glial cells. Glial cells are support cells within the nervous system. Under normal conditions, they help maintain neural environments. They regulate chemical balance, and they support neurons, and they clear out waste. But during chronic stress, chronic inflammation, and persistent nerve injury, those glial cells can shift into an activated inflammatory state. And once activated, they begin releasing inflammatory cytokines directly into the spinal cord environment. So now inflammation is no longer only occurring in the peripheral nerves. It's also occurring inside of the pain processing system itself. That distinction matters enormously because it helps explain why patients often plateau when the approach only focuses on symptom suppression. You're not just dealing with irritated nerves in the feet anymore. Now you're dealing with a sensitized processing system that has biologically adapted around chronic threat. Everything I just described is biological. That means it is measurable and is not psychological weakness. When a patient tells me their bed sheets feel like fire, I believe them completely because I understand that their nervous system has reorganized around threat detection in a way that allows light stimuli to generate real pain signals. That sensation is real. The pain is real, and the mechanism is just not what most people would expect. Now, psychological distress absolutely interacts with with central sensitization. Fear amplifies the threat response. Hypervigilance amplifies threat response, and feeling out of control amplifies the threat response. Feeling dismissed or not heard can also amplify the threat response. But that doesn't make the original pain psychological. It means the nervous system responds to the entire environment, physical and otherwise. And I also want to make something else very clear. Central sensitization is not unique to neuropathy alone. I've seen it in patients after major car accidents. I've seen it after brain surgery. I've seen it in people whose nervous systems went through prolonged physical trauma and never fully settled afterwards. Sometimes the original injury improves structurally, or at least partially, but the nervous system, it remains stuck in a heightened threat state long after the original event. The system stays hyperactive, hypervigilant, and overprotective. And once that state becomes established, the person starts reacting disproportionately to stimuli that normally would not produce that level of alarm. So when we talk about central sensitization, we're talking about a nervous system adaptation pattern that can happen after prolonged overwhelming stress on the system. Neuropathy is one pathway into it. Trauma is another, and surgery can be another. Chronic inflammation is another pathway that's often overlooked. All different roads, but very similar nervous system behavior once sensitization becomes established. And this is where treatment approaches can sometimes become incomplete. If peripheral nerves are still damaged, still hypoxic from compromised blood supply, still under metabolic stress, and still firing abnormally, then education alone does not remove those biological drivers. Pain education matters. It's important to understand why you have going on what you have going on. Helping patients understand this helps take away some level of fear. But the peripheral environment, it still matters. You have to address both. Because if the peripheral drivers remain active, the central sensitization still has fuel. And this is where I think a lot of neuropathy conversations become oversimplified. Peripheral nerves require oxygen, they require blood flow, they require metabolic stability, and they require an environment that supports repair instead of ongoing stress. If blood sugar volatility continues damaging nerve tissues, the peripheral signal, it will continue. If the microvascular circulation remains compromised, the peripheral signal will continue and get worse. If systemic inflammation remains elevated, and the peripheral signal will continue to get worse. And if the peripheral signal continues long enough, the central nervous system continues adapting around it. That is why the peripheral side of the equation still matters so much. And this is also why recovery usually requires more time than patients actually expect. You're not just trying to calm the symptoms, you're trying to change the behavior of an entire nervous system that spent years adapting around a threat. Now, that takes consistency and it takes repetition. It takes gradual recalibration. And this is where aggressive treatment approaches can sometimes backfire. Because a sensitized nervous system already is operating in a very high alert state. Its threshold for alarm is already lowered. Its response to new input is already amplified. So what happens when you introduce aggressive, high-intensity interventions into that system? Sometimes the nervous system interprets the intervention itself as an additional threat. That's when patients try a treatment and they think that it becomes worse because they flare up because their body is already more reactive. Now, that is a sensitized nervous system responding exactly the way a sensitized nervous system behaves, which means the treatment approach has to match the biology. The nervous system needs repeated experiences of safety. Even with CS, reducing ongoing peripheral stresses, improving metabolic stability, supporting circulation, lowering inflammatory load, and providing graded non-threatening input, giving the nervous system enough consistency and enough time to recalibrate itself gradually. Now, not over days, it could be over months or even longer, because that's how long it takes biology to actually change. Now remember, this is a biological process, and biological processes can change when the inputs driving them change consistently over long periods of time.